Hi, everybody. Welcome back to the Beyond podcast, where we chat all things about how you can live beyond those labels. I'm your host, Dr. Flora. Today, we have a really fun and whip-smart guest. Today, we have Dr. Ashley Winter, who is a board-certified urologist and sexual health specialist. After finishing her urology residency in New York City, she did the only fellowship available here in the United States for urologists in both male and female sexual dysfunction. She currently practices in Los Angeles, California, and sees patients for all things related to orgasm, arousal, desire, sexual pain, and hormones, including one of our favorite topics, menopausal hormone therapy and testosterone therapy. She is a mom of two and is a very long time, very loud advocate for sexual health on social media. Hi, everyone. You are listening to Beyond, and I'm your host, Dr. Flora. Listen, life is hard. You don't have to do it alone. As a mindset coach, physician, mom, and an infertility warrior, I have mastered techniques to help move you towards contentment and growth. I can't wait to go along with this crazy-ass life journey with you while making sure you feel like your best self. This podcast is meant to have you feel unstuck from your rut and less alone. Let's do this. Ashley, thanks so much for joining me here on the Beyond podcast. I'm really excited.
Thank you so much for having me. We were just talking before we started recording. I have a 2-month-old and how it's just so exciting for me to be doing my first podcast since giving birth because, newborns are absolutely lovely, but they don't talk to you very much.
Let's rewind a little bit. So you are a urologist. You are also a sexual health specialist. Now, for all of our listeners here, and I think I get patients also confused by different specialties. Most people have heard of a urologist and what they deal with. Most people have heard of a OBGYN, general gynecologist, and what they deal with. Where do you, Ashley, fit in between the urology and the world of gynecology?
Yeah, I guess I fit in kind of in between.
That's kind of how I would describe it.
Yeah. I mean, the penis and the clitoris are essentially the same organ, right? If you look at them under a microscope, they both have erectile tissue. They both have 2 erectile chambers. They both have a gland that's really sensitive. Mm-hmm. That is the primary way that people achieve orgasm, through exposure to that. And I don't want to be so reductionist because I don't only see people for clitoris and penis problems, but when people say, men are from Mars and women are from Venus, it's so not true, right?
Yeah.
We are so similar, just kind of like certain components of our bodies are just rearranged a little differently or sized differently. And I feel like, and I think many obstetrician gynecologists will tell you this as well, that, their training is highly based on female reproduction, or preventing female reproduction, right? Contraception, managing bleeding of reproductive organs, managing cancers of reproductive organs, but pleasure and genital sensation and sex are not necessarily the core areas of their training or what they're led to care for, right? And that's not out of any desire not to, it's just the way that field has evolved. And similarly, urology got into the field of sexuality by being really focused on helping people get boners, but very much
specializing in men's sexual pleasure, desire, and health. Yeah.
Right. But also certain things are missed in there, right? Like we're trained all about erectile dysfunction in residency, but thinking more broader about men's pain with sex, post-ejaculatory dysfunction, being a good partner, things like this. This was not part of our training either. And so there's this really big space that lays in the intersection of all of that, both for men and women, that's saying, how do we get you to have pleasurable, pain-free sex? Or how do we get your body to the place where you can do that if you wanted to, even if you're not sexually active, right?
Because I think important. It's a quality of life,
important.
I think. And I think we as a society, I have patients that continue to come in and they're all really shy and they're like, I know it's not super important, but I can't get it up, is literally like what the guys will say. Or a lot of my perimenopausal, menopausal women will be like, I feel bad because I just don't have the desire. I don't feel like having sex, or I'm dry and it's painful, and that, and then it's embarrassing to talk about for a lot of people. But I always just say, this is a part of quality of life. Like if you are in pain, like if you have knee pain and it hurts to walk, you're not gonna be a very happy person. So if it hurts to have sex, an activity that you once enjoyed, then that is also a quality of life issue.
100%, 100%. I mean, we feel like we don't deserve to care for this the same way we care for other parts of our body, right? And it's so interesting when I see, like, again, a man will come in, or a woman will come in and say, I can't get an orgasm anymore, or I can't get an erection anymore. But I guess that's just part of aging.
Yes.
So I don't deserve treatment for it. And I say, what's also a natural part of aging essentially is like cataracts, right? Like 90%, something like 90% of adults, if they've been outside enough, get cataracts, right? And that's just exposure to the world makes you get cataracts. But you believe that vision is a fundamental part of your bodily functions, right? Your bodily functions, and that you deserve to care for it. And so you go and you get cataract surgery, and then you can see again. But when something doesn't work with our genitals, we don't give ourselves the same benefit. And I want that to be fundamentally the same, right? So
yeah, that's such a good point. What do a lot of your male patients say when they walk in and they see, like, you walk in and you're like a pretty doctor? Or I know they're obviously there for a specific condition. They're seeing you knowing they're going to talk about their reproductive parts, but is there any embarrassment?
Yeah, it's so funny. So, I mean, now I have a private practice and people know who I am before they see me. So there's no surprise. I used to work at Kaiser Permanente, which is, a large managed care organization. If people aren't familiar with it, maybe they're not on the West Coast or areas that have Kaiser, you'll get referred to a specialist by your primary care doctor, and you probably will get whoever you get. Yeah. So there were a number of people who had the appointment with me and they just saw Dr. Winter on their schedule and they had no idea who I was going to be. And I did a lot of the specialization in male conditions. For example, I was the main doctor that treated Peyronie's disease, which is abnormal curvature of the erection. Some erection is curved. So that did happen. And there were times that I would walk in the door and somebody would be notably uncomfortable, or, I mean, even so much that I had a patient look at me and say, I was hoping you were going to be a man. Literally just
what
he
say
said
to that? You're like, sorry, do you want to like reschedule?
I did. That's what I said. I said, I'm sorry, if you're not comfortable, you can reschedule. And he said, no, I waited too long for this appointment.
There it is. I waited too long. There it is. I know a lot of, I work at Cedars, so employed doctor under a managed care system, but a lot smaller than Kaiser. And oftentimes we see each other as patients, just, we work as a team. And so a lot of my male colleagues' patients, because they can't get into their primary care doctor, they'll come see whoever they can first see. Now, all of our pictures are on the website. Like, they can see my first name. Flora, I believe, is a more female related name, first name. And they walk in and they're just like, they're sweating. They are just like moving around on the exam table. And I'm like, look, if you want me to bring a third person as a chaperone, a male chaperone, I'm happy to do so. Otherwise, like, let's help you. I'm here to help. We're not here to judge. We're not here to really, make fun of any. This is your body. And then I go back to the quality of life talk. Like, if it hurts or if something feels uncomfortable or if you're anxious about a body part, regardless of where you are and where it is, you deserve to be treated and cared for and evaluated. Like, it's okay if it's your penis or 100%. Your testicles or your scrotum or whatever, right?
No, so totally. So I will say probably 99.99% of the time, the people who either expressed that they had wanted a man or seemed uncomfortable, by the end of the appointment, they were comfortable. And there were a number of reasons. One, I would approach their issue very matter of fact. And when I just start asking questions, oh, so it's a penis issue. Tell me what's going on. And then follow-up questions and follow-up questions. And suddenly they realize that they've opened up about this thing that they had been keeping inside of them. And I was not being judgmental. And it just, the issue goes away. I mean, it really does. If the doctor is not acting prudish and uncomfortable, the patient responds to that.
Absolutely.
And then sometimes I would have a patient say, I tried to talk to so-and-so, the male urologist, or who did my prostate surgery, or I tried to speak to my PCP, who was a guy, and they were both very uncomfortable talking about my penis.
Really?
And you are.
I'm surprised.
Yeah. And then as a final point, if I see that they're, in a heterosexual relationship, I'm like, who do you usually talk to about your penis, or who usually looks at your penis? And it's their wife. And I'm like, okay, so if you have spent most of your life showing your penis to a woman,
I get that now.
It's okay.
I get that now.
Yeah.
That totally makes sense. I'll have patients start making jokes. Like, oh, you're the second woman that's ever been down there. And I just don't entertain it, because if I start joking, when they start joking, it kind of breaks that patient-doctor relationship.
Sure,
and it's not appropriate for me and to feel comfortable. So I think that also helps to just, they may joke out of discomfort. And if you kind of just breeze past it and talk in a matter-of-fact tone and terms, I think you're right. I think it really does help. And then what about female issues? What type of female issues do you normally see?
Oh my gosh, so many things. So many things. I mean,
what's the most common? Let's say top 3 common things.
Top 3 common things would be genitourinary syndrome of menopause. So, when your hormone levels go down, increased risk of not only pain with sex and vaginal dryness, but also recurrent UTI, pain with urination, symptoms similar to interstitial cystitis, overactive bladder, urinary incontinence. So this comes in to me a ton. And other similar conditions like hormone-mediated vestibulodynia, which is very similar spectrum of symptoms due to low hormone levels. Usually it's just not due to menopause. It's due to something else. So these are younger patients coming in with similar symptoms and ultimately getting similar treatments. So that's number 1. I do see a lot of recurrent urinary tract infections. And I also do see in my current practice quite a bit of clitoral adhesions. So,
really? So what are the causes? First of all, let's talk about what clitoral adhesions are and what are they caused by most commonly?
Yeah. So the penis, has a foreskin, and the clitoris, obviously if somebody's circumcised, they no longer have a foreskin, but if somebody's not circumcised, they have a foreskin. And the clitoris has a clitoral hood, which is the same as a foreskin. It doesn't wrap all the way around. It goes like a hood, right? It's just kind of on the top and the sides. And the way that men with a foreskin can get phimosis of their penis, where the foreskin doesn't pull all the way back, you can get the same thing with the clitoris, where the hood cannot pull all the way back. And you really don't usually notice the relationship between the head of the clitoris and the clitoral hood until there's a problem, right? So you have people coming in and they have certain conditions that cause that clitoral hood to get tight and cover over the clitoris. So common examples, there's a condition called lichen sclerosis, which is actually much more common than people realize.
I was just about to say that. That is so much more common than, we don't talk about it enough. I don't think I learned about it really until I got menopause certified. And I'm like, oh wait, I forgot about this condition that we kind of just breezed through over medical school.
Yeah. Oh yeah. I mean, it's considered a rare disease. If you look it up on the internet, it says lichen sclerosis is a rare disease. It's not a rare disease. It is.
I think it's underdiagnosed. Yeah.
It is an underdiagnosed, under-discussed condition because people are not empowered to look at their vulva, or they think it's just normal that it's inflamed, that it's white, that it's thick, that it's itchy, that it's closing up. And they don't talk to anybody about it, right?
Yeah.
Or they think
and then oftentimes they don't do, when they go to their general practitioners, they don't get a pelvic exam. And so, the most common symptoms, itchy skin, they're like, oh, it's probably a fungal infection, or sensitivity, change your detergent, just very general advice and treatment plan without physically taking a look at the vulva or at even the pelvic region, just overall And so
Yes.
it is important to have a proper evaluation just from a patient perspective. Y'all are listening and you have an issue, any of your body parts, it is really important to physically have someone certified physically look at you, because
Yes.
yeah, we can guess all day, but I mean.
And this is the importance of, in our training, in our medical schools and everything, to make physicians comfortable with genital exams and trauma-informed care. Because I think a lot of doctors think that trauma-informed care is not having the patient take their pants off. But then what that means is that in our quest to make people comfortable, we neglect their genitals. And if they have a problem there, they need to examine. So we need to be comfortable examining them and figure out the ways to do that comfortably. So as you're saying, having a chaperone, taking the time, asking permission, explaining how you are doing your exam. And I'm really digressing, but again, as you say, it is important. If somebody comes in and they say, oh, I'm itching down there, we don't just assume that it's a fungus and say, like, wear some kind of underwear and use this antifungal cream and go home. Like, you might have lichen sclerosis. And as we know, that lichen sclerosis, when untreated, can lead to vulvar cancer. And if it's treated, you don't get vulvar cancer, right? I have one time posted just about lichen sclerosis. Multiple women on social media will come and say, I didn't know about lichen sclerosis until I was diagnosed with vulvar cancer, and I wish I had known. And you're like, this could have been prevented, right?
How sad. Yeah.
How sad. And how many cancers can you prevent with a steroid cream, right?
Do you ever feel like you are juggling a million things at once? Especially if you are a business owner. You're trying to grow your business, but also, run your business. It can feel like you are drowning in your to-dos with barely a moment to breathe, let alone dream bigger. I have been there. Now look, I tried hiring a gamut of virtual assistants, but it often felt like there was just one other thing on my to-do list. I had to spoon feed tasks, constantly check in, recheck their work, and still worry about things slipping through the cracks. It wasn't until I found Savannah and Natalie at Every Virtual Solutions that I truly understood the difference between help and the right kind of help. They have extensive marketing, development, and executive assistant backgrounds, so they can take the weight off of your shoulders so you can focus on what you do best, being the visionary. Book a free discovery call on their website and mention this episode for a 10% discount for your first 6 months. Head over to everyvirtualsolutions.com. That's EVERAE virtualsolutions.com. Whether it's web design, content creation, email management, social media, PR, or anything in between, I know you will find a way to work together to lighten your load. It's time to end the burnout and start focusing on you. Correct. Simple. So lichen sclerosis is a cause of
clitoral adhesions.
Clitoral adhesions. Okay.
I know. But that's one of the causes,
a really piece
right?
of it's a really important piece of information, though. So I'm glad we did digress a little bit into that.
Yeah, totally. I like talking about this because, again, right, so many people have never heard of it, and then they're like, wait, I think I might have that happening down there.
Yeah.
You also don't have to be post-menopausal to have lichen sclerosis. Even kids get lichen sclerosis. Like,
I've diagnosed it in 20, 30-year-olds who, from a hormone standpoint, regular cycles, everything else, it was just caused by, a variety of other issues. But absolutely, you don't have to be perimenopausal or postmenopausal.
Yeah. So the clitoral adhesion. So let's say, right, lichen sclerosis, just one example where you can get fusion of the clitoral hood and the labia minora over the clitoris. And so I have somebody come into me and they say, I had months or even years of loss of orgasm or pain in my clitoris. And maybe I had been told, oh, you're not having an orgasm, drink a glass of wine, or, oh, you're not having an orgasm, watch some porn, or, oh, you're not having an orgasm, buy a vibrator. But the problem is that if the skin is completely used over your clitoris, it's can be really hard to have an orgasm, right? Like, especially if you're somebody who primarily orgasms from clitoral stimulation, which is the vast majority of clitoris owners, right? I mean, so
I like how you say clitoris owners. I've always wondered how to verbalize some of those, nowadays.
yeah, totally.
Okay, interesting. All right. So clearly you see a wide range of pathologies and medical concerns and issues. And we kind of touched base on this. Why is talking about sex and sexual health still so uncomfortable for women?
I don't have a good answer. I mean, I think we're just taught it's dirty or something.
Yeah. Yeah, no, you're right. And even as doctors, as you mentioned, we don't get the proper education. I don't think I'm just trying to think. I feel very comfortable with anatomy. And so I don't feel uncomfortable doing pelvic exams in male or female patients. But I'm just trying to think of how much education I actually got in medical school and exposure. I don't remember really, especially to male physical exams.
Yeah. It's interesting. I remember I got consulted to like do a physical exam on an inpatient psych patient because the psychiatrist wouldn't do it. And they said they wouldn't do it because it would disturb the therapeutic relationship they had with the patient to do the physical exam on the genitals. And it's one thing if they would just say to me, hey, I haven't done an exam on somebody's genitals in X number of years. And I don't feel,
yeah.
Right. But the concept that seeing a patient who is admitted to a hospital, doing a complete comprehensive physical exam on them, including their genitals, would destroy the therapeutic relationship. But examining any other part of their body would not destroy the therapeutic relationship is, again, like putting this kind of derogatory value
You're right.
on the genitals, right? I mean,
right.
I understand if you're on outpatient therapy with a psychiatrist, you're not expecting people to take their pants off and do an exam.
Yes.
But if somebody's hospitalized in an inpatient unit, I don't know.
I get it. I think it's the societal stigma that I think that we've all created, right? From multiple generations before us. It's the stigma that I think has been created and it has carried over into medicine. I mean, just with the example that you were mentioning, how some of your patients haven't had a physical exam and they're coming to you and you were the first person to look at them and actually do a physical exam for their ailments. So I think, that all of this, whether it's right or wrong, it all makes sense and we understand why it's happening. But I agree. I do think it's important to slowly break that stigma. I mean, especially within our culture, the South Asian culture, I mean, there is still a lot of stigma about your private, quote unquote, private body parts. And we weren't taught about sex. I started my period and I thought I was dying because no one told me about it, right? And then like the only thing that my mom told me is like, don't let boys touch there. That's it. And so I'm like, oh, okay, so I'm just going to bleed half to death once a month and then move forward. And then here I am in medicine, specializing in women's health. And it's just interesting, but our generation will hopefully break that stigma for our kids and make them feel comfortable talking about their body parts when appropriate and when indicated and without having that, that stigma. I think being embarrassed is normal. And I think, wanting to maybe feeling unsafe or uncomfortable is normal in teaching our kids when it's appropriate and not appropriate. But I hope they do recognize that this is a body part that still deserves care.
Yeah. And talking about these body parts and children knowing about these body parts, I mean, it doesn't make them less special. Like people see my lips, I still kiss my husband and that's different. Right? Like,
that's such a good point.
And again, I'm not a nudist. like I've had, but the point being that showing it to your doctor, that's not the same act as intimacy, right?
Yes.
It is fundamentally so different. And so we shouldn't go into it with this act like it's shameful to show it to somebody because you're not it's not like you're walking up to somebody and just showing them your genitals, right?
Absolutely. Yeah, this is a
Yeah.
closed and hopefully safe area of concern where you're discussing your concerns. I know
Yeah.
on the perimenopause, menopause talk is really a hot topic now. You're a menopause certified practitioner, as am I. We have been, at least on social media, where we are primarily on, I hear a ton about estrogen. I hear about a ton about progesterone, and when we are treating, that is usually the focus. But there are studies about testosterone, and yes, listeners, females, we have testosterone in our body. It has a lot of importance. Ashley, can you break down just an overview of the importance of testosterone in women and the importance of checking and treating it?
100%. So, as you say, women have testosterone. In fact, in the average reproductive age woman, there is more testosterone floating around in your body than estrogen. In a biochemical pathway, it is a precursor hormone, right? Testosterone actually gets converted into estrogen. There are different pathways you can arrive at estrogen, but you have more testosterone in your body than estrogen. And I think it's important to mention that because people talk about women's testosterone as, oh, it's so little. If you have it or don't have it, it's not a big deal, right? It is clearly a fundamental molecule in our body and it affects our entire body. So that's number one. Your ovary makes testosterone. Your adrenal glands also make some testosterone. But this is important to know because, for example, if you have your ovaries removed for some reason, maybe, ovarian cyst, risk reduction for ovarian cancer, something like that, you are going to have, on average, about 1/2 of the testosterone that a woman who goes through natural menopause has. So even after menopause, your body does make some testosterone. That's what the data shows. So that's important to know if you're somebody who has had bilateral oophorectomy, right? Both ovaries removed, is that you will have less testosterone. So in terms of what it does, right? I will just talk about the things I know the best first, right?
Sure.
So again, themes. I was talking about how the penis and the clitoris are similar, right? The genitals of all humans are sensitive to testosterone. So your clitoris, if you have no testosterone in your body, your clitoris shrinks. This is a fact. And actually, in addition to perimenopause, menopause, certain really common medications like combined oral contraceptive pills lower bioavailable testosterone and total testosterone in women. This is a fact, right? If you look, there's large meta-analysis showing that every single type of combined oral contraceptive pill reduces testosterone. And why does it? Because you give the synthetic hormone, your brain senses that synthetic hormone. It says you have all these hormones, you don't need to make more. And so it shuts down ovarian production. Of testosterone, right? So when you shut down ovarian function with a combined oral contraceptive pill, you're not just stopping ovulation, you're also reducing testosterone production. Really interesting stuff. And the wild thing, right, is that we have so many young women who are put on combined oral contraceptive pills at a young age before they become sexually active. So they actually don't even know what sort of sexual being they would be with their natural, so to speak, testosterone
I guess I never really thought about that. So what is the impact of lowering your testosterone levels? Say, for example, let's take a woman of reproductive age on oral birth control.
Amazing question. The most robust data is that testosterone is responsible for driving our sexual desire. We also know that there's robust data that it affects, again, your ability to orgasm, right? If your clitoris is all shrunken up, it could be hard. It could be less sensitive, right? It could be hard to orgasm. You have less lubrication, okay? There are two types of lubrication. There's the lubrication from your vagina. That's something called a transudate. I'm like nerding out for your listeners.
Totally. I love it. I love it. I go into science all the time.
Yeah, it's right, so there's two types. There's the type in your vagina, the blood vessels in your vagina dilate, fluid comes out. Great. There's also the lubrication that comes from these glands right around the opening of your vagina. That tissue is called the vulvar vestibule, and there's glands there. And all of those glands are very dependent on testosterone. And that is a huge part of your lubrication. And that's not transudate, that's glands pumping out really nice lubricant. And so those glands won't function as well. So you can have dryness. And particularly, you're going to have some listeners who identify with this. Their vagina will lubricate in response to stimulation or response to something going in their vagina. But this area, this vulvar vestibule, will not, particularly if their testosterone is low. And they'll feel this dryness, discomfort, or razor blades near the opening of the vagina. And when a penis or a dildo or their hand goes in there, there's discomfort near the opening. And a huge part of that is related to low testosterone levels.
Fascinating.
Yes.
So if someone on oral contraceptives comes to their doctor and says, hey, I have lost my sex drive, or sex has become slightly more painful, but I still don't want to get pregnant, I am not ready to start a family, or I'm done with family planning, what are different options?
Yes. This is a great question. Yay. So, I mean, you could leave them on the birth control and give them testosterone.
Yeah.
Not the best option because you're not addressing the root cause, which is the medication. Correct. The other options, right, would be an IUD, intrauterine device, if they can use that, right? Even the hormonal ones have a very low dose of a synthetic progestin, usually levonorgestrel, and that is not going to have as much of an effect, but they still can stop ovulation.
Yes.
So they still can reduce your ovaries' production of testosterone. What they won't do is raise something called sex hormone binding globulin, which the oral estrogens always do. So it's not going to have as much of a negative impact on the testosterone levels, those IUDs. And then, of course, there's the non-hormonal IUD, which doesn't stop ovulation, the copper IUD. And so that would have the least effect of the IUDs on your testosterone level. Again, some people don't like it because you have generally heavier bleeding on it.
And you still get your period, and some don't want to see their period. I've had an IUD before. I thought it was fabulous. Like I still hate getting my period. I do my birth control back to back. I skip the placebo week. So just FYI, TMI, but it's okay.
Not TMI.
But it just helps. I don't like getting my period. So I know the copper IUD really turns a lot of my patients off. They're like, wait, I'm going to be bleeding more. I think we do need to weigh the pros and cons. I mean, with everything that we have available, unfortunately, or 110% condom use. And when I say 110%, I mean like no mistakes. No slip ups if you're not wanting to family plan.
For sure. And I will tell you, I know a number of people married in relationships, had their, let's say 2 kids, they were 100% done. As they said, okay, we'll just use condoms. And then at one time they didn't use a condom.
I know.
They got pregnant and suddenly they're having another kid. So
I know. Or they're going through, an abortion because they don't want, they felt very strongly. And that's a whole other traumatic incident. So I totally get it. There's no perfect thing, unfortunately.
The progestin only pill is also going to be less of a negative impact than the combined pills, right? So the combined pills, for people who are listening, have a synthetic estrogen, usually something called ethinyl estradiol, and then a synthetic progestin. And the progestin only pill is going to have less of a negative impact on testosterone. So you can use that. But again, that is, you have to be 110% compliant with when you take it and taking it. There's less wiggle room, and it is easier to get pregnant if you miss a dose with the progestin only pill.
Yeah, I think on all oral contraceptive boxes, it does not say 100% effective because they account for human error. So it's like 98 or 97. Yeah. I don't remember.
The other thing I would say, a great solution if you are in a long-term monogamous relationship, is to have your partner get a vasectomy.
Yes, I am always telling people to do this. It is a non-major outpatient procedure. I feel so strongly about this because the amount of female patients that have walked in for a pre-op for a tubal ligation or a hysterectomy, just strictly for contraception and not because of a medical indication, my brain just it short circuits. Like I'm short circuiting right now. I get so upset because
Yes.
the risk is the risk just far outweighs a vasectomy.
Yes.
Really, it does. It just
It does. It does.
I'm getting all warm because I get so worked up about this.
I love how worked up you're getting because, as you know, when I was at Kaiser, I would do vasectomies all the time. It was one office appointment. I mean, it was local anesthesia. I mean, it's like going in and, I don't know, getting a teeth cleaning or something, right?
Correct.
You go in,
with like a slightly longer recovery.
Right, except the difference is you can, drink hot liquids after you get a vasectomy.
Yeah.
We did it in the office. We used numbing medicine and they walked out and it was fine. And
fine.
I just, it's upsetting to me, particularly in couples where there's children, because the risks that a woman goes through to generate children.
Correct.
Like the risks of pregnancy and childbirth is so astronomical.
Yeah.
That when you talk about reproductive stewardship in the family, step up and get a vasectomy.
That's the least you can do.
Exactly. Exactly.
I had a patient who told me that her push gift was her husband to get a vasectomy. She's like, I don't want any jewelry. I don't want any fancy purses. I'm done. I don't want to do this again. I am traumatized. I love my children, but I'm done. And so that was the agreement. That was her push present. He was going to get a vasectomy and they're going to live happily ever after. So, and it
seriously, that is the best push gift because you can buy yourself jewelry.
You're totally right.
Like if I really want fucking jewelry, buy your
own jewelry and purses, ladies.
Yeah, like you can give me the joy of you having a vasectomy and me not having to worry about birth control anymore.
Yeah, birth control, hormonal imbalances, all the potential side effects. No, and I do want to reiterate that birth control is widely used and there are many, many patients that do not have any side effects, but it is important to be aware of potential side effects that could be related to any form of oral contraceptives and be empowered to bring that up to your doctor and not just take it because you don't have another choice. You do have other options and it might take some trial and error, but that's okay.
That's an excellent point. And I should say, when I bring all this up, I am super pro birth control. I'm not anti-birth control. I myself have a hormonal IUD right now and I love it. I have had one before and I loved it then. The oral contraceptive pills are phenomenal for lots of people. I mention it and I think it's important to bring it up because if you are on a combined oral contraceptive pill and you're experiencing things like pain with sex, vaginal dryness, just any sort of vulvar pain or low libido, this is something to consider. This is something, what are my options, right?
Yeah. And correct me if I'm wrong, but topical testosterone or any form of testosterone is not medically approved for use from a female patient, correct?
Yes. Yeah.
So it makes it really tough to get and expensive.
The only country in the world that has a FDA approved testosterone for women is Australia.
That's right. I knew there was one. I didn't remember which one.
So we use it off label for women. Sure. In my practice, I prescribe it all the time off label. But yes, it's not technically designed for women. And because of that, also, it's not covered by insurance. That said, there's generics widely available now, so people can get it for a pretty reasonable cost because women use such a low dose. With a good RX coupon, it ends up being approximately $10 a month, something like that. It's workable, but it's definitely not covered by your insurance, which is.
So when should a patient ask their doctor to check testosterone? It's not obviously in their annual physical. I mean, it's not involved with their annual physical, just basic labs. Oftentimes when patients ask for quote unquote hormone testing, like the most common thing I get. Check all my hormones, doctor. I think I have chronic fatigue syndrome, and I think my acne is working out. I'm not losing weight. All the things, right? And I have to go into the explanation from a Western medicine standpoint, what that actually means and what's involved. So at what point should a patient expect to get their testosterone tested?
Yeah, great question. I mean, if you're expecting your general practitioner to order it, that's never going to happen. I mean, at least to my knowledge. I mean,
I don't order it.
You are the internist.
I don't order it. The only time I do order it if someone is perimenopausal or menopausal having symptoms related to low testosterone. But in general, no, I am not. I'm not even checking estrogen and progesterone in your annual physical. It's not part of guidelines. It's not indicated. But yes, when indicated, but I'm one of very few, I'm assuming, primary care doctors that will check testosterone. It's just, I think, a lack of education, a lack of knowledge through no one's fault. I always give the caveat that we did not learn this shit in med school. Like nobody taught us about perimenopause and menopause and all the hormones that are involved in it. And just recently, again, in the last maybe few years, we've started seeing these, buzzwords and a lot of the marketing around vitamins and supplements for women related, female related, this transition time related symptom treatment plan.
Yeah. Well, you have it exactly right. If somebody is coming in and they have symptoms related to low testosterone, then we check their testosterone. If somebody is on birth control or combined oral contraceptives, or let's say anything else that might inhibit their ovulation, such as hormonal IUD, we can check it. I know it's going to be low. So if you come to me and you have, you're taking your combined oral contraceptive and you have low libido, I'm going to say we don't have to wait for you to get labs to make an intervention. We can just make an intervention or talk about that, right?
That's a very similar verbiage I use with perimenopausal symptoms as well. Like your labs aren't going to change my management. And obviously for my menopausal patients, when it comes to estrogen and progesterone, yes, that might affect what I put them on. But agree. Yeah. And I think sometimes patients are so obsessed with having the numbers, but we treat the patient. Right? Like it's a clinical judgment. Yeah.
100%. Well, that's also, I mean, when you talk about estrogen and progesterone, if somebody's in perimenopause and they're still cycling, right?
Yes.
Then you have to treat their symptoms first because their levels are going to be all over the place. And even if you try to time it to the follicular versus the luteal phase, which can affect the levels of the hormone, the fundamental issue is, particularly in perimenopause, that you can have what we call anovulatory cycles, meaning cycles where the egg is not being released. You can have irregular periods, right? So you can't always capture that. Yeah. And what you shouldn't end up doing is get a hormone panel on somebody who's in perimenopause. They come back with normal labs and then deny them treatment based on that.
Correct. Yes. Oh my God. The amount of times I've seen that, it's heartbreaking.
Yes. You have to just say, this is a snapshot, this is a moment in time, but what's important is the amount of estrogen, the amount of progesterone you have produced by your ovary over time, right? What is that area under the curve of what dose you're getting from your own ovary? And if we know we know it can go down. And if you have symptoms associated with low estrogen, right? If you come in and you're saying, I have vaginal dryness. Yeah. Fine, I'm 47, but I have vaginal dryness. That's a symptom of low estrogen. I'm going to give you some vaginal estrogen. Maybe we're going to talk about an estrogen patch. But like you say, we have to treat the patient and not the number. So it's interesting in terms of checking testosterones, right? When we look at guidelines, there are guidelines on using testosterone in women. There's a consensus guideline from the International Society for the Study of Women's Sexual Health. Okay. And there is a consensus guideline from them for the use of testosterone in women for hypoactive sexual desire disorder, aka low libido. And they do mention obtaining a testosterone level at baseline, not to diagnose low libido, but to establish the baseline, basically, because if you're going on treatment, you do follow the testosterone level. Makes sense. Reason why you follow it is to make sure you don't overdose, right?
Yeah, because totally makes sense. We do the same for men as well.
Yeah. Right. Yeah. And more importantly, if you're staying in what we consider the normal physiologic female range, the risks are astronomically low, right?
Yeah.
Astronomically low. I mean, there's what we know from the data is there's no increased risk of thromboembolic events or blood clots. There's no increased risk of cardiac events. There's, to our knowledge, it's extraordinarily safe. But if you get too high, right, if you're getting in that range of 200, 300, this is where we're looking at like a male level, what can happen, and this is the most kind of dreaded, is to have a voice change, right? Because the voice change doesn't go back. You can get other things like some hair on your body, you can get increased size of your clitoris. Again, these are things you're going to notice probably over time, and you can peel back and reverse for the most part. But if your voice cracks, that's like, that's a change.
It's irreversible.
Right? Yeah. So you need to dose it correctly. And because of that, when you start somebody on low dose testosterone, you follow their lab to make sure they're in the right range.
Absolutely makes sense. We got to find that sweet spot. Okay, I'm going to go through some quick fire questions because I think this will be really fun. So we're going to talk about maybe like 1 to 2 word answers. And knowing me, I'll probably ask you like to explain because I'm always curious. But are you ready?
I'm not good at 1 to 2 word answers.
I know. I'm not either. That's why I love doing this.
Oh God, that's so hard.
Question number 1. Peeing after sex prevents UTIs. Medical fact or myth? I know.
Fact-ish. Fact.
Okay. Now I actually need to know why. So wait, what does that mean?
Yeah, the data's not excellent on that. There's no prospective randomized trials where they told a bunch of women to pee after sex and looked at their rates of UTIs and compared them to women who didn't, right? There is no study doing that. There isn't. So we just take it on
anecdotal,
and that it just seems to make sense, right?
Yeah. Right. Yes.
Like, and
I like that. Okay.
Yeah.
Fact-ish, not based by the most, pristine randomized control trials. But
pee after sex, it is increasing the frequency, so that's why I say it's kind of fact-ish. But
yeah, I like that. That's a good answer. I'm happy with that.
Yeah.
All right, your favorite body part, not on you, but just in general in life.
Oh, I said scrotum.
Oh, interesting.
I like the scrotum.
Why? Okay, so for those,
I mean, it's not my favorite body part. But obviously I don't have a scrotum.
So for those who don't know, a scrotum is a male body part at the base of the penis.
It's the ball sack.
It's your balls, and it's like a sack of skin, and it includes testicles, epididymis, vas deferens. Did I get that right?
All of that stuff sits in the scrotum. Yeah.
Yes.
I just, as a urologist who has done surgery on many body parts, doing surgery on the scrotum or the contents of the scrotum, such as the testicles and the vas deferens, and it's just very nice surgery. It's just it's easy to access, right?
Okay.
It's easy to access. Sense. It's the scrotum is very forgiving. Like it's very stretchy.
Yeah.
When you have incisions, when you cut into the scrotum, you can close it up and you don't see anything.
Yeah. Okay. Get it.
It's lovely.
It's like a low
funny. It's kind of funny
surgery. It is kind of funny looking.
Yeah, I love it. Right. It's a great organ.
Yeah, the scrotum is not my favorite part, but I don't know what it is, but it's not the scrotum.
Yeah, I think it's a great organ.
Weird gut reaction. Talk about like societal, stigma. Anyway, next question. Kegel exercises, overrated or underrated?
Both.
Okay. Again, explain, because Kegel exercises, again, are being talked about everywhere. A lot of primary care doctors recommend Kegel exercises. Obviously, I counsel on how to do them and when to do them, but they're not always done right or indicated.
Exactly. So they're overrated when they're not done right. And unfortunately, I do think a lot of people don't do them right. Or they're overrated when they're done for the wrong reason. So I have patients who come in and, for example, they're pelvic pain patients with a high tone pelvic floor.
Yeah.
And they are having pelvic pain and they've heard that part of the problem could be their pelvic floor. So they start doing Kegel exercises or Kegel exercises. And that actually makes the problem worse. Yes. Right. But they were like,
sounds painful if you're already having a contracted muscle and tight muscle. Yeah.
Right. But they're like, I have to take control of this body part. It's probably related to my pelvic floor. I need to exercise it. And it's not always the best. So it's
So how do you
overrated
do a
in those
Kegel exercise
scenarios.
correctly?
Yeah, I mean, it's a great question. I mean, sometimes a way you can explain it to somebody is like try to start and stop your pee
Yeah.
is a good, I don't know, how do you counsel people on
Same
how to
thing.
do it?
So
Yeah.
I describe it like that, but then I also tell them that you, from like an exercise standpoint, when indicated, you need to hold it. You can't just squeeze. It's like doing a bicep curl and just rushing through it versus, a patient actually last week was telling me that I do 100 Kegels on my way to work, like while driving. And I'm like, oh, how long's your drive? And she goes, under 10 minutes. And I'm trying to like, I'm like, how long are you holding your Kegels? She's like, I'm not. And I'm like, and so there are
Yes.
multiple apps that you can download that like, they're like these, I used to have it after I gave birth. I, had pelvic floor issues. So Kegels were recommended by my pelvic floor therapist. And so I downloaded this app. I don't remember what it was called, but they were just bells. And so like you hear a bell,
Ah,
you do your Kegel and you hold until like another bell at another tone, and then you let go and then you do it again. And so it
wow.
just makes you more cognizant of when to squeeze and hold and let go.
That's great. There's also even apps that come with a device that you put in your vagina that
What?
measures pressure.
Oh,
Yeah, there's one even that's like a video game. Like you squeeze it to make the thing on the video game jump
OMG.
up over obstacles,
Oh
like
my
imagine you have a
God.
little Super Mario and he's
Oh
running
my
along
God.
and he
I'm
needs to
dying
jump
right
over
now.
the
I
thing.
actually want to
So
buy
you
this because I'm curious about my pelvic floor strength.
you should do it. You should do it. I forget the name, but there's
I'm totally
multiple
going to look it
different
up.
ones you can buy. And you have an app and you have the thing in your vagina and you squeeze it, it makes the thing jump up and you can like play video games
Oh
and it
my
can tell you
God.
how
That is
strong your
marketed
pelvic
for
floor is.
people like me, like who are like competitive. Like, oh my God, I'm totally gonna look this up. And if I find it, I'm gonna like post it on the podcast information page.
Yes, please do. But I maybe do a live stream of like the screen of your video game, not like
Oh
obviously
my
your pelvic
God.
floor, but like we can all
Oh
cheer you
my
on
God.
or
This
something. I don't know.
podcast is coming to YouTube soon. Maybe it'll be a future YouTube video and I'll just put the screen up and not
Yeah.
really show anything else.
But talk about a way to incentivize you to do them,
Absolutely. Yeah,
right? Because then you're like,
absolutely.
oh, I have this log of when I did it, and I see I
Yeah.
got this far on the course, whatever. Like,
Yeah.
yeah, so it's fascinating. It's great for things like stress urinary incontinence. It's great for, if somebody needs to figure out how to hold their urine in certain instances.
Mhm.
Obviously, it can exacerbate overactive bladder, but it is good to have this power over it. So in that respect, it's good. It's also underrated because I think Kegels are often not used for treating sexual dysfunction. But Kegling appropriately can help with erectile dysfunction and it can also improve orgasms in women. Because
Mm.
when you orgasm, you clench your pelvic floor, right? And you recruit the muscles in your pelvis and at the base of your penis or clitoris, and you recruit those muscles. And Kegling effectively can help facilitate the
Yeah.
engorgement, the hardness of
Makes
your
sense.
genitals. So
Yeah.
it's great for sex, and it's often just thought of as like a pee thing,
Yeah,
and it's not
that
just for
that's
pee.
fascinating. Gosh, there's so many things down there. I love it. I love it. Okay, if
There's so
you
many
could,
things.
there's so many
There's so
things. There's
many
so
things.
many things, and
Like
they're
people
all interconnected.
interconnected, and people are
Yes,
like, "What do you do with the sexual medicine?" I'm like, "There's so many
there's so
things.
much. God, we could
There's
talk about
so
this
much."
forever. Literally, like there's medical and quality of life issues that are impacted when something isn't working. But yet we don't know as a population, as a society. I feel like we don't know when to go to our doctor or if this is normal to go to the doctor for. And you're saying, yes, there is.
Yeah. I mean, just think about it, right? You have how many women have 20 different face creams and they've never looked at their vulva? Like
Yeah.
it's
Yeah.
just
I
as
agree.
it's a complicated body part. It's
Take a
also
mirror, friends. Take a mirror
yes.
and just look, and Google in this case can be your friend, and identify different body parts. And it is okay to utilize the words and know what's there. Because here's the thing, if something, God forbid, does go wrong, at least what's indicated, when it's indicated to go to your doctor, your gynecologist, your primary care doctor, a specialist. Because if you don't know what you don't know, that makes sense.
Yes.
And
Yes.
so take a mirror,
Yes.
do a little, friendly self-exam.
Yeah.
Okay,
100%.
one
I
last
mean,
thing
that's
here.
how you advocate for yourself. Yeah, yeah. Sorry.
Absolutely, absolutely. One last thing. If you could ban one piece of bad medical advice forever, 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 like the biggest medical hoax you've ever heard of, there are many, what would it be?
Mega doses of vitamin C for boosting the immune system. I hate that one.
That
And
is
it
the
always,
biggest hoax. You know where that came from, right?
like Linus Pauling,
Yes.
apparently.
It's like this Nobel
Yeah.
Prize winner from the 60s. I think he was a chemist, I
Yeah, and he
believe.
won for something totally not
Completely
related to vitamin
unrelated.
C.
And then I remember doing research on this. Well, okay. First of all, I'm going to just shamelessly say that if I feel myself like getting a cold, I have emergency in my pantry and I will chug. If it's a placebo, I will take it. I know I'm going to pee probably 3/4 of that vitamin C dose out. But look, it makes me drink more water. And we always recommend, you got to increase your fluids when getting sick. So if that is what's going to motivate me or anybody to drink more fluids. But going back to the science, I think your tissues in a day can only absorb up to 200 milligrams of vitamin C. And a lot of those mega dosing packets have like 1,000 milligrams. So,
and there are people who take way more than that. I mean, the 1,000 milligram is not that big of a deal, but there are people who are taking 10 grams in a day, right? So 10 times that.
Yeah.
And yes,
and that's not including food, like the vitamin C that you get from regular fruits and vegetables.
Yes. And I will tell you, it's so funny about the emergency because I used to do that. And then what happened during peak COVID, so many people were taking tons of vitamin C for immune boosting, which there's absolutely no data that mega dosing vitamin C boosts your immune system. Zero, right?
Yes, let's add that part in there too. There's no scientific data supporting that. Yes.
And it's so important to differentiate the difference between having megadoses and a deficiency, right? Having deficiency, vitamin C is scurvy and that is bad for you. But once you no longer have a deficiency, adding more doesn't help you. And so we're in COVID, peak COVID, and people are megadosing tons of vitamin C. And what ended up happening is that I started getting all these people coming to my practice with kidney stones, needing kidney surgery because of vitamin C. Because vitamin C causes kidney stones.
I did not know that there was a surge in kidney stones.
Yes. So for people listening, vitamin C, when you drink too much, it doesn't just go into your urine and make expensive pee. Vitamin C, when it gets excreted into your urine, becomes something called oxalate. The molecules are very similar, and oxalate is one of the main drivers of kidney stones. So people would take a ton of vitamin C, not boost their immune system, get oxalate in their urine, and form kidney stones.
In the hospital.
And still end up in the hospital. And I'm like, if you had just not taken the vitamin C, you wouldn't be in the hospital.
Oh, that is so ironic.
I got so upset about this that now, like, my husband will buy the emergency for his cold or flu. And I say to him, Mo, you know that excess vitamin C is only excreted into your urine and it causes kidney stones. Why are you taking that? It's a placebo effect.
Total placebo effect.
It's fizzy.
I am the first to admit that it is a placebo effect. I still have it. I don't take it daily now. Thank God. I don't get sick very often. But I chug that thing and whatever. I get 32 ounces of water in me, and just in one sitting, I'm okay with that. And I feel okay.
The 1,000 milligram, you're going to be fine.
Yeah,
I will say people shouldn't be scared of eating a lot of fruits and vegetables because when you eat vitamin C in, for example, citrus fruit, it's very balanced by a lot of citrate, and citrate inhibits kidney stones. So this is just one example of why eating real foods, right? Whole foods, real foods, has so many more nutritional benefits than taking isolated vitamins, because there are intelligent ways that nature has packaged this, right? And so it packages vitamin C with a kidney stone inhibitor like citrate, which is very cool. So
science is so cool.
It's very
And
cool.
it
It's
makes
very
sense,
cool.
which is why we're
Yes.
here.
Yes. Yes.
Ashley, thank you so much. You have imparted so much wisdom. And I really, really hope our listeners here, even if it's one piece of information, or even if they had a moment to be like, oh my God, I need to go to my doctor because I've actually experienced or am experiencing this. And I'm just going to bite the bullet and ask. I really, really hope somebody gets something out of this. So thank you so, so much for taking the time and going through all the things.
Thank you so much for having me. I'm so happy you invited me on.
Of course. And beyond listeners, if you found this episode helpful, the best way to support the show is to hit that follow button on your listening platform. Make sure you leave a quick rating or review. Share it with your mom, your sister, your friend, your colleague, anyone who needs to hear this. Let's continue to help each other, really living beyond these labels that society has put on us, these boxes that we tend to live in. Your support means the world. Ashley, before I forget, where can people find you if they want to see you as a patient, or if they just want to get some free advice on social media?
Yes. Well,
Not free advice. Hold on. Free education. Let me just
education.
Yeah.
Yes, that is true. I don't post medical advice. On Instagram, Twitter/X, and TikTok, I am all Ashley G Winter, ASHLEYG like grape, and then winter like the season. I started my socials before I was an MD, so that's why. And not all of them. TikTok didn't exist, obviously.
That's how old we are. Yeah.
Way too old for TikTok to have existed
when
I.
Same.
But. And I am in practice in the LA area. I see patients in Pasadena physically, but I also do telehealth. I see patients from all over the country. I would love to have you as a patient. And the easiest way to find me online in that capacity is through our practice website, which is actually rachelrubinmd.com. That was the founder of our practice. And then you can find me on that page, and that has the telephone number.
Awesome. We will post all of that information on the podcast info page, so it'll be an easy click away if you would like to see Dr. Winter as a patient, or if you would like to follow her on all the multiple social media platforms for wonderful, useful, amazing education about your health. All right, listeners, thank you so much for tuning in. And as always, remember, mindset is medicine. Keep showing up for yourself, and I'll see you next time. Bye. Thank you so much for joining and spending your precious time here with me. As someone who prioritizes her energy, I am so grateful that you chose to spend yours here. To help me help you, please take an extra 30 seconds of your time to rate and review the podcast on your listening platform. For more tips and a behind-the-scenes look into my life, follow me on Instagram at Dr. Flora Sinha. That's Dr. Flora Sinha. Finally, connecting with you truly fills my cup. So DM me on Instagram, email me at florasinhamd@gmail.com, repost if you love this episode. I love hearing from you. I am so grateful for you and cannot wait to be back for the next episode. Bye.